So if you want to be an all-star pain doctor or an all-star pain patient, this episode is for you. Hey everyone, Dr. Dustin here. Welcome to another episode of the Dr. Dustin Show. Tonight we're going to talk about the Stanford Five. Now, I touched on this before maybe a couple times, but I felt like tonight this really deserves its own episode just because of how important it is. And not only is it important for pain doctors to be able to not only be efficient, but also make an impact, I think it's important for pain patients to know about, to come to the visit prepared. And even if you don't get asked these questions, these Stanford Five questions, you can volunteer the information and blow your doctor away. So to begin with, the Stanford Five is quoted from Sean Mackey. This was published in the Pain Chronicles in 2010. So this has been around for some time, but in practice, I think it's still maybe not as popular as it should be. And I think that's the case because of all the stories I hear from patients. The dreaded first patient visit, the first evaluation, maybe switching pain doctors, and all the anxiety and fear that goes into meeting someone new, being vulnerable with someone, deciding what information you feel like you want to give, what information you feel like you should keep close to the chest, and really just kind of feeling out the situation. Is this a doctor that's going to listen to you, that's going to see you eye to eye, that's going to believe you, and that's going to be able to provide treatment that you're looking for? Okay, a lot of that is maybe not even covered in that first visit. Maybe a lot of it is sort of drug out over 2 to 3 visits because so much of the time that we have to spend together is very limited, and a lot of it's just quick information gathering and going forth with that. So the impact that can be made, however, on a first visit really does, I think, or can make or break the relationship long term. And as we know in pain management, the relationship a pain doctor has with their patient really is everything. There's so much subjectivity in pain management, and there's so much consequence when things are miscommunicated, when things are misunderstood, or when honesty is not part of the equation. And so that's why I think this is so important, this Stanford Five, because it sort of lays the groundwork, sort of a rapid speed dating questionnaire, if you will. And like I said, I don't think physicians are really asking these questions. I remember in training, we weren't asking these questions, and I've worked with probably a dozen or 2 dozen different pain doctors in my time, and nothing against the pain doctors. Like I said, there's different ways of gathering information, but this, I think, hits it all succinctly and efficiently. So let's get into it. Number 1, these are the things that should be asked about the patient. So number 1, patient's belief about the cause of pain. So if I'm the doctor and you're the patient, I'm going to ask you, what do you think is causing your pain? And if you are very quickly and succinctly able to give me an answer, then that helps me know how to approach the situation. For example, if you have back pain and you're like, well, doc, I had an MRI, I saw a surgeon, it's this one disc at L4-5 and it's pushing right on my L5 nerve and it's causing pain to shoot down my leg, and I'm here because I need somebody to help me with it. Bingo. Cool. All right. Well, right then and there, I can confirm your story with a focused exam, a review of your images, and I can say, yep, sure enough, it's what it seems like. Well, you've already done all the conservative treatments, physical therapy and whatnot. So why don't we go ahead and move forward with an injection and see if we can't cool this nerve off for you. Now, right then and there, I met the patient where they were and offered a treatment approach, which is probably why they're there, obviously, as quick as possible to feel better. Not wasting any time, meeting expectations, covering all our bases. Fantastic. Now, if the patient says, yeah, I really don't know what's causing my pain. You're the doctor, right? How many times have I heard that? Well, you're the doctor. Well, I know that. I'm just trying to figure out where you're coming from. So if that's the case, then I know that, all right, well, this patient has a big question mark as to what could be causing their pain. And so that means I not only need to do my diagnostic approach, but I need to demonstrate my diagnostic approach so that the patient can feel as though their needs are being met. Because a lot of times when patients, and this has been my experience and maybe yours too as a patient, but a lot of times from my perspective, when a patient doesn't know what's causing their pain, at least half the problem is just not knowing. I think in a lot of cases, knowing what's causing your pain can be therapeutic in and of itself, right? If you feel like something crawling on your leg and it's in the middle of the night and it's dark, I mean, I don't know about you, but my thoughts immediately go to scorpion. Okay, there must be a scorpion on my foot. That's the only thing that could be crawling on my foot right now. And it's the middle of the night and I'm woken up from sleep. And actually, this did happen to my wife. We live out in the country, and I swear we built our house on top of a scorpion habitat of some type. And so we've always been battling these scorpions. I mean, they're everywhere. You open up the silverware drawer and they're crawling around your forks. It's just insane. So there was a time there where in the middle of the night, you'd be feeling something crawling on your foot. Terrible. So if that's kind of how you go into the doctor now, in this blindness, feeling something crawl on your foot, you're going to think the most worst thing possible at that moment. And that's terrible. That's terrifying. You're going to lose sleep over it. Your anxiety and heart rate and respiratory rate and everything's going to be upward driven. So if I can turn the light on and show you that it's a harmless little carpenter ant and he's just looking for something to eat, it's still something crawling on you, but it's not a scorpion. So everybody can okay, we can calm down. I now know what's causing that little sensation I'm feeling on my foot. And you know what? I know you can blast it away with a pressure washer, but I don't really want to go through all that effort and resource right now. I'm just going to live with the fact that I know that there's an ant crawling on my foot. So same exact pathology going on, but just the knowledge of knowing that it's not a scorpion can be enough for some people. And so that's why it's so important for us to know or to ask about what the patient thinks is causing their pain. Number 2, what is the meaning of this pain? So there's this idea of, okay, well, we know what's causing it. What's the meaning of it, right? Somebody comes in with back pain and, I want to know what's the story that they are telling themselves around this back pain. Do they think it's cancer? Maybe because they have some family history or personal history of cancer, and now they have this new back pain, and this is what's keeping them up at night. Are they worried that every time they move, they feel pain and there's damage occurring, such as damage to the nerve? Are they going to become paralyzed if they decide to bend over and tie their shoe? Right? Is that what the pain means? Or does it mean that the pain is so severe and so chronic that they're going to become disabled and they're no longer going to be able to do the things they like or provide for the family like they once provided for them? And now this whole crisis of identity comes into play with this back pain, right? So it's important to me as the physician to know, what does this pain mean to you? And again, as a patient, you should have an understanding of this and present that to your doctor, because again, a lot of times if the diagnostic approach or the treatment approach is not aligned with what you even think is going on, if we're not answering that question, right? If in your head you think, well, it's got to be cancer, and then we never talk about that in our visit, and then you go home and you still think to yourself, well, it's got to be cancer. And then you ruminate over this overnight. Well, if the doctor thought it was cancer, he would have asked me about it, right? Or maybe he would have ordered new imaging if he thought it was bad, right? But he didn't, so it must be okay. And you just go through this cycle of despair trying to microanalyze the whole doctor encounter. Don't do that. Don't do that. So much haze and fog can be removed from the environment if we just, hey, what's going on here? What does this pain mean to you? Tell me the story that is going on in your head so that I can understand where I can meet you and lend a hand. I hope that makes sense. Number 3, what is the impact of pain on your life? Now, we talked about this in isolation, certainly. This idea that the pain scale is pretty much meaningless. You go into the doctor, oh, my pain's a 5. Oh, my pain's an 8. 8 seems to be a comfortable number for most people. Can't quite say 10 unless you're, can't move and you're crying and things like that. But 8 seems to be like I can believe that, right? Because it's a game. You want to be believed. And so, again, but I look at the pain scale as being relatively useless in isolation. I mean, we can follow trends like within you, right? If like you first came to see me and your pain was an 8, and then 6 months later your pain is a 5. And, it's like, okay, well, we seem to be making some progress here. Or something else that might occur. Let's say you come in, your pain's a 7, you're on a ton of opioids. I'm like, hey, you're on like a lot of drugs. Like maybe we can cut back a little bit because I don't think it's really helping, after, proper building of rapport and information gathering and whatnot. And let's say we come down from 150 oral morphine equivalents to, let's say, 75. And you come in and you're like, yeah, my pain's a 7. And you're unhappy, my pain's a 7. And I can be like, well, okay, cool. But, your pain was a 7 like 6 months ago, and your pain's a 7 today. And I realize we're not making much progress, but guess what? You're like on half the amount of medicine that you were once on. So if anything, we're just reducing your risk, your pill burden, your side effects, all of that nonsense. So there's still some benefit to be made, even if it's just not the pain scale. But again, the point is the pain scale is not the best way of measuring pain. So we talk about presenting our situation as a matter of function, right? And so it's like, hey, I was once able to do this, and now because of my pain, I'm no longer able to do that. And that's extremely informative because, again, it tells us visually and even emotionally how this pain is impacting you. And it can not only lend itself to some diagnostic utility, but it can also give us some reasonable treatment goals and ways to measure your progress along the way. Which brings me to point number 4. What are your goals as the patient? What are your goals? Now, I understand most patients, their goal is not to go from a 10 to a 0. It's not realistic. It's not realistic to go from a 4 to a 0. This idea that we can live without pain is unbiblical. It's just not possible. It's unscientific to some degree. Now, we can live above pain in most cases. That's the goal anyway. We can live free from pain, right? In the sense that Americans are free, but we still have laws and rules and regulations and taxes and all these things that we don't like that we could arguably say makes us less free. But again, in total anarchy, are we really free also? So, I mean, that's a whole nother debate, but that's my point, is that we can never live without something, in the absence of something, and we don't want to. We don't want to. Pain is useful. It keeps us alive. It lets us know things are going on in our body that we should tend to. So I know that patients don't want a 0 out of 10 pain. That's not new news, at least in most cases. But what are your goals otherwise? Well, I want to, do this one thing with my family member. I want to go on this trip. I want to go on this cruise. Hey, doc, we need to schedule the injection in the next 2 weeks because I'm going out of town and I want to have a good time. So these are goals, right? And a lot of times we talk about, don't do an intervention that doesn't last, or like an injection. An injection only lasts 3 months. Why would you ever do an injection? Hey, man, maybe you got things to do in those 3 months. Okay, I mean, compared to medication only lasts 4 hours, so you got to keep doing that over and over again. And that, of course, comes with its own side effect profile long term. So, again, Not to say that medications are not the answer or injections are not the answer. It's just, where do we need to meet you at this moment in time in order to accomplish your goals? Objectively, in a list format, but also over time. What are we looking at here? Some patients are just looking to postpone surgery. It's like, hey, my doc told me I need a knee replacement, but I do not want to go through a knee replacement. It's too much work. I already had that done. I did the rehab for it on my left side many years ago. It was terrible. I don't want to do that on my right side. Is there anything else we can do? Well, sure. We can burn the nerve. We could put in a wire. We could do some more therapy. We could inject some more medication, steroid, hyaluronic acid, PRP if we can, depending on the situation. So, like, yes, there's options. Are all these options going to last forever? No, probably not. Are they all perfect options? No, probably not. But are we able to get you to a point where you can feel that you're back to doing what you want to do with the limited amount of time that we have in our lives? Right? So again, what are the goals? And it's important for the physician to know these goals. See, I think a lot of times the physician's goals are, I got to get you to procedure, got to get you procedure, got to write more meds, or not write more meds, whatever your goal is as a physician, right? We have our own sort of business-oriented goals in that sense. And it's okay to have those, but I think it's a shame when that bleeds over into the patient encounter or supersedes the goals of the patient. The patient is there for a reason, and it's not to serve you, the doctor, right? We're here as physicians to serve our patients. And so, I think the greatest success that we can measure ourselves by is not by the reduction in opioid prescriptions. It's not by the high volume of injections. And it's not even by the 5-star reviews on Google. No, the way that I measure myself, and other physicians too, is when a family member calls the clinic and says, hey, ever since my partner, my daughter, my son, my parent has been coming to see you, they've been doing so much better. We were able to go here and do this and travel and go out to eat, live life. And when I get that response, or even a family friend referral, that's how we should measure ourselves. That's how we should measure ourselves. That's really what it's all about. Improving the quality of life for those who depend on us to help them in that dark hour. All the rest of it is, I'm going to say earthly, worldly. Being a physician is not an easy job. Ask my wife, ask my kids. I'm always working. Most physicians are almost always working. And that's been one of the challenges of this podcast is, many of you may not realize it, but I'm still seeing between 40 and 60 patients a day. I have help. It's not all me, but I'm signing that many charts at least every day. I'm rounding at the hospital. We have clinic. We're doing procedures. And somehow, between all of that, I still have to take care of myself, take care of those that depend on me. So, no, it's not easy to be a physician, but it's extremely fulfilling. And I think that's why it's so sad for me to see other physicians sort of turn or orient their career into worldly outcome measures. Because that, to me, is where all of the heart and soul gets lost. And that's, to me, what leads to physician burnout and addiction and divorce and all these things that are just prevalent, really, in society, especially the physician group. It's not easy. Now, I'm not complaining. This is like the best job ever. But it's because we're answering a call that is outside of it's bigger than us. It's bigger than us. And that is, I think, how we should measure ourselves. And the only way to do that is to align yourself with the patient's goals. The patient's goals, not your own. The other side of that, of course, is if a patient comes in and like, hey, I want, 500 hydrocodone. Like, wait a minute, hold on now. No, that can be harmful, right? Just because the patient has a harmful goal doesn't mean we should pursue that. But I think you understand what I'm trying to say. Last but not least, number 5, the patient's perception of the appropriate treatment. Now, this is huge, and I have found a lot of benefit just asking the patients. It's like after I gather all my information, I'm like, okay, now before I tell you what I want to do for you, right? Because I feel like I have to like let them know I already have a plan. Because if I just ask them, like, what do you want me to do for you? Then they're going to ask, well, you're the doctor. You tell me. Okay, so I stopped doing that. So I said, before I tell you what I want to do, tell me what it is that you're expecting me to do. Okay? Because again, I don't know always where you've come from. I know what you've told me, but I don't know if you've seen 3 other pain docs and they all give you the same answer. I don't know if you have this just unspoken fear of anesthesia or needles and surgeries, and you just don't want to do that. I don't know if you're anti-opioid. And then if I offer an opioid, you're all offended. What are you, a pill pusher? Right? I don't know if you're pro-opioid and I totally avoid the subject of opioids, and then you're like, oh, he's just another needle jockey. You see the dance that we have to do as a physician in order to meet you where you are? But it's not impossible. The answer is, what are you expecting? Tell me. I want to know. I want to know where I can best meet you. What are your fears? What are your desires? How can we meet each other halfway to help you meet your goals so that you can reduce some of the impact of this on your life? You can change some of the meaning of this around your life, and you know what it is, and you can go on and not have to think about visiting a pain doctor every 2 days. That's a good thing. That's a good thing. So yeah, knowing what it is that you're looking for. If you're coming in, you're like, hey, like, I'm not interested in any of these diagnostic tests. Like, I got the minimum. I'm convinced I know what it is. The surgeon's convinced they know what it is. All I need is an injection and I'll be on my way. Cool. That makes it easy for me. Check, boom. See you in a couple of weeks. Feeling better. But if I have a lot of patients that are like, hey, man, I've seen 3 docs. No one seems to be listening to me. It's like pulling teeth just to get an MRI, let alone anything else. Like, somebody's got to tell me what's going on with my body because something is definitely not right. Okay, let's figure this out. Let's figure this out, because that tells me, again, we have some work to do, not only on the diagnostic side, but maybe even on the treatment side, in order to up the ante, so to speak, in order to make sure that you are feeling that your needs are being met. That's a good thing. That's a good thing. So this is the Stanford Five. These are the 5 things. Number 1, patient's belief about the cause of pain. Number 2, what is the meaning of pain from the patient's perspective? Number 3, impact of pain on life, again, from the patient's perspective. Number 4, what are the patient's goals? And number 5, the patient's perception of appropriate treatment. Now, you can answer all these being a patient, and you can ask all of these being a good pain doctor. So hopefully that helps you in your next patient visit, in your next pain management visit, and hopefully you were able to get some solid ground under your feet as you navigate these treacherous waters ahead. Until next time, continue living more with less pain, and we'll see you later. Bye-bye.